Hi guys, I'm Maylin Dovan, certified athletic therapist and founder of Rehab-U Movement and Performance Therapy, and welcome to our YouTube channel. If you haven't subscribed yet, make sure you do and hit the bell. This week we're going to go over a case study about hip impingement or hip pain in the golfer. So a client of mine, a former pro golfer, came to me with a history of groin pain that had previously been treated as adductor-related groin pain, so treated like an adductor strain or adductor tendonitis or so have you. In the initial assessment, so groin pain is a huge umbrella term. So in the initial assessment, one of the most important things is to be able to classify that groin pain. So what I mean by classify it is it of iliopsoas origin? Is it adductor related? Is it inguinal related? Is it pubic related? Or is it hip related? Because it could be that as well. Any of those things could create pain in the groin. So when someone comes to us with groin pain, first order of business is, can I kind of classify that groin pain and work my way from there, okay? Given you don't have any imaging or any other kind of thing like that, okay? So because Simon, my client, had been treated, or what he'd done so far had been treated as adductor-related groin pain, obviously I wanted to check if that was the case. Now, when I talk about, I'm going to show you a couple of things. So when I talk about being able to categorize groin pain, for example, if you want to know if it's adductor-related, if it was adductor-related, there'd be local tenderness in the adductors close to the origin, and pain on resisted adduction. So if you did a squeeze test where I'm going to ask Caroline to squeeze her feet together, she would have pain on that resisted adduction. Or even with the knees bent, if I had her squeeze the knees together, she'd have pain on that, okay? If it was iliopsoas related groin pain, again, she would have tenderness in the iliopsoas. She would have point tenderness there, and then her pain would be on resisted hip flexion. So as she resists me into hip flexion, that would be what creates pain, okay? Now, those are the kind of tests that you'll do. If she had inguinal, if it was inguinal related, she would probably have pain right in the inguinal canal, and her pain would be more on abdominal resistance. So if I had her try to come up and do like a bit of a crunch, or she would, there you go, or she would self-report pain with things like coughing, sneezing, Valsalva maneuver, so holding the breath in those squats and deadlift, that kind of stuff, if it was inguinal related. Pubic related groin pain, I won't go into in great detail. There aren't any specific rule outs in the same way as iliopsoas. There's a lot of other stuff in the history, as with the other kind of tests. Again, you would do your full assessment, okay? But understanding that, at least that helps you kind of categorize if there's pain on the adduction, resisted adduction, then, and no other pain on the other movements, then I'm looking at adductor-related groin pain, okay? Now in Simon's case, there wasn't any pain on the adduction on the squeeze test. Now another place, another origin of groin pain, as I mentioned before, can be that it can be hip-related. Now in Simon's case, his pain was deep in the front of the hip, and he would also get pain in the back, in the area of the SI joint and the lower lumbar area. That's where he would also get pain, which kind of triggered me to think maybe we're dealing with a bit more hip-related groin pain, okay? Now, looking at hip-related groin pain, how do I categorize my groin pain as hip-related? Then you would need to go through your full hip assessment, okay? But typically, the history will tell you a little bit about it, and things like bringing the hip into flexion, adduction, internal rotation, which we call fadir, so flexion with adduction and internal rotation, they'll be irritable on that, okay? Now, compare the good side, because sometimes this can be irritable for pretty much anyone. If you really get into flexion, adduction, and internal rotation, there's going to be a bit of a pinch sometimes for people even on the healthy side. So make sure to look at both sides. So for Simon, my client, this was irritable. Another thing that he told me was irritable was, he said that when he would lift the foot to cross his ankle over his opposite knee, that would really trigger pain. So I also went through Patrick's test, which is the test you cross the foot over the knee. Now, if you do this and they get groin pain or muscle spasm in the groin, that can be indicative of hip-related or hip pathology, okay? Patrick's test is a good test to differentiate between hip pathology and SI joint dysfunction. If it's SI related, they'll get pain more when I push on opposite ASIS and push the knee down towards the table. They'll get pain in the area of the SI joint in back. But if I bring them into this position and they spasm in the front or deep in the hip, that's more indicative of hip pathology, which was the case for Simon, okay? So other things that Simon presented with was general weakness of the hip musculature, so weakness of the psoas, weakness in abduction, weakness on resisted adduction, so not pain, but weakness, so general weakness of his hip musculature. Difficulty with his balance, so single leg balance on that side. And on a single leg squat test, for example, we saw a little bit more difficulty controlling knee valgus and hip adduction, which were all overall things that pointed to, let's treat this like a hip issue. So his intervention was built upon treating it like a hip issue, namely a kind of FAI, so a hip impingement approach. Okay, so I'm going to go on to explain a little bit about what the objectives were in his phase 1, for example, what kind of exercises we used and why, based on the fact that we decided to treat this like a hip impingement. Hey guys, thanks for watching our videos, and don't forget to subscribe to our YouTube channel. So there are several characteristic modifiable impairments in people who have hip impingement or femoral acetabular impingement, and one of those is hip muscle strength. And we talked about how Simon had decreased hip muscle strength. So one of the main focuses of his first phase was really going after those deep muscles of the hip. He's a former pro golfer. He's got a lot of hip internal rotation, tapped into that mobility a lot in his career, but now we need him to kind of control that range of motion and really activate those deep hip rotator cuff muscles, same way we would want to reactivate our rotator cuff muscles. So the internal external rotation control exercises work really well, where Caro is just in a seated position, and from there she's going to move into internal rotation, and she's very focused on that axis of rotation being an axis through the femur and not hiking up the hip as she does this. And as she gets to her end range, she just imagines that she's pushing into that end range. So that's internal rotation. Now, if that was irritable, if she was getting a little bit of a pinch, I would ask her to stop just short of that pinch initially, okay? And I typically program these for 5 times 10 seconds. So as she gets to that end position and pushes into that end range, she holds for 10 seconds and does 5 times. External rotation is just the opposite. She just needs to move this leg out of the way or move the other leg out of the way and make sure that she can get enough space to get her internal rotation. And here we want to make sure she doesn't go into any flexion. So a lot of the times, naturally, the pattern that we have when we do this is I'm crossing my ankle over my knee, right? So she's got to make sure she keeps that axis of rotation through the femur, and she's not going into hip flexion. Same idea, 5 times 10 seconds, okay? So in an activation sequence, we're really getting after those deep muscles of the hip and reactivating those deep muscles of the hip using repeated isometric contractions. Now, another thing we want to go after is hip flexion and getting into a hip flexion position with that lumbopelvic stability. So controlling the pelvis as we move into hip flexion to isolate those hip flexors. So a standing band march is a pretty good exercise here, really easy to do. So Band is at the feet, moving into hip flexion and making sure that when she gets to that end range, she doesn't tuck the pelvis. So she's maintaining, so this, the contact leg is pushing into the ground and the other hip is flexing up. So making sure that she gets that control and works on that hip flexion position. Now, same as the internal external rotation control exercises, I often do this instead of reps. I'll often get people to come up into hip flexion and hold that for 10 seconds. And then do 5 times 10 seconds on the one side and 5 times 10 seconds on the other side. And we can progress to a supine band march, which is a little bit more difficult because it's a little bit harder to control the pelvis. Starts in a 90-90 position and pushes out with the one leg and maintaining that knee over the hip. Good. And again, same idea, you could do this for reps. You could have her push out and hold that extended position for 10 seconds. Alternate or do all one side and then all the other side for 5 times 10 seconds. So manipulate that as needed. Now the adductors are also important. Simon had worked on the adductors a lot and that wasn't a wrong thing to do. Adductors, abductors, all of the muscles that impact the hip are important. One nice way to get hip extension as well as adduction is this bridging exercise with a band resistance into abduction. So pulling with the band, so I pretend I'm the squat rack, so I'm actually pulling her into hip abduction and she's doing a hip bridge and resisting that abduction force from the band. Okay, so working on the adductors and hip extensors, always focused on maintaining that neutral pelvis. All right, now another characteristic, modifiable impairment that we see in people with FAI, I talked about decrease hip muscle strength, also decrease in trunk muscle strength. And I like to link that with the hip rotation control. Now, typically when we think of a Pallof press, we think of it as a core exercise, which it is, but we often forget that, I'm gonna be the squat rack here again. So we often forget that as she gets into a split stance position and does her Pallof press, she needs to resist rotation of her trunk, but she's also resisting rotation in her hips. She's resisting that temptation to have that front knee falling in or have that back knee even falling in. So there is some rotation control in the hips there, okay? Now, it's fairly light with a Pallof press in the sense that most of what you'll feel is going to be that trunk rotation control, a little bit less in the hip, but we can increase that with, for example, a pitchfork raise, which is similar but is going to use more weight. And again, we want her to keep that nice hip alignment as she raises the barbell forward. So again, lots of core trunk work, but there's hip rotation control work going on there as well. There's some anti-rotation stuff going on in the hips as well for her to maintain that alignment, okay? You're good. So what we don't want to see on the Pallof press when someone is in a hovering split stance Pallof press is that knee turning in, which is something initially we saw with Simon and we had to cue him to control that. So for him, it was really a core and hip activation exercise, okay? Now, again, there's always gonna be an integration sequence linked to all of these exercises that are a little bit more rehab-based, so you wanna be able to load that person. So again, think about wanting to improve that hip muscle strength and getting him out initially of any hip impingement position. So things like lateral step-ups will be really interesting because you strengthen the adductors and hip extensors, that kind of stuff. But eventually you might progress him to crossover lunges, crossing back, and actually getting that hip into an impingement position, right? Because what we take away at the beginning, because it's irritable, is the goal towards which we need to work. They need to become tolerable to those kinds of things again. So guys, hopefully that helps you if you're dealing with clients who have hip impingement or clients who come to you with groin pain. So the idea of being able to kind of classify that groin pain and then know what you're going to need to go after is really, really helpful. And if it is hip related, if there is some impingement, the exercises that I showed you are really important, having that focus on the deep muscles of the hip and working on all of that trunk and hip control is going to get you very far with these kind of clients. So hopefully that helps. And on that note, we will see you next week.